Hello, doctors and friends. We are from Small Group Discussion B9, here to present our student project with the title Emergency Airway Management in Patients with Head and Neck Trauma. My name is Grace Valerie with the last three digits to the number 143, and I'm going to present about the background. Head trauma is a common case in emergency departments that can cause disability, morbidity, as well as mortality. Patients with head trauma can have respiratory-related conditions such as chain-stop breathing, hyperventilation, ataxia, apnea, and even respiratory arrest. Neck trauma happens because of three major mechanisms, which are blunt trauma, penetrating trauma, and strangulation. Dyspnea, stridor, hoarseness, dysphonia, subcutaneous air, or hemoptysis could occur as signs of airway injury results of neck injuries. Airway management in trauma patients begins as early as the time the first responder arrives in a pre-hospital setting and continues until a definitive airway is maintained in an emergency department. Airway management focuses on opening the airway to allow adequate oxygen and ventilation. That's all from me. Thank you.
Hello doctors and friends, my name is Stanislaus from Wangsadinata with the last three digits of student ID 115. Now I'm going to explain about the clinical anatomy of the head and neck. The first one is the head. Structures and the anatomy of the head is divided into several groups. The first group are the bones. The most superior part of the head is the calvaria, which is composed of the frontal, parietal, temporal, and occipital bones. Moving inferiorly, it is composed of the sphenoid and ethmoid bones. The second group are the vasculatures. The anterior part is supplied by the common carotid artery, and it branches into several carotid artery, which is the internal and external, and it may branch into two important branches such as the maxillary artery and the middle meningeal artery. The internal carotid artery will eventually form the circle of Willis. The last group are the nerves. Skull is the main channel for which several major nerves arise through the foramens. Those nerves are called the cranial nerves. The next part that I'm going to explain is about the neck. The neck region is divided into three different zones accordingly. Zone 1, area in the zone includes the whole contents between the clavicle and the cricoid cartilage. Vessels in Zone 1 are comprised in common carotid artery, vertebral artery, subclavian vessels. Nerves are the brachial plexus, and organs are the trachea, esophagus, apex of the lung, and the thoracic duct. The second one is reflects the area between cricoid cartilage and the angle of mandible. The contents examples are carotid artery, vertebral artery, internal jugular veins, and then the organs such as trachea and esophagus. The third zone is the inferior from the angle of mandible. It expands until it reaches the base of the skull. It only consists of distal carotid and vertebral artery and also the pharynx. Maybe that's all from me. Thank you.
Let me introduce myself. My name is Siemarga with last digit of student number 134. Today I will explain about the etiology of head and neck trauma. A meta-analysis in 2021 found that road traffic crashes were the most prevalent etiology of maxillofacial trauma. And for head and neck trauma, there are falls, violence, and sports among children and adolescents. Etiology of craniofacial fracture based on the location in the upper frontal sinus, middle naso-orbital ethmoid, zygomatic-comaxillary complex, and orbital in lower mandibular and dentoalveolar. Etiology of neck trauma, there are two: penetrating and blunt. Penetrating classified by the anatomical zone of entry as they can delineate vascular and other structures that may be injured, and in blunt, laryngotracheal airway and cervical spine are the most susceptible to injury. That's all from me. Thank you.
Hello, my name is Eyn Awdy Afza with the last three digit number 102, and now I will explain about pathophysiology of head trauma. Head trauma is a significant cause of morbidity and mortality worldwide, often leading to complex pathophysiological change. One of the critical complications of severe head trauma is airway obstruction. This phenomenon can occur through several mechanisms. Neurological impairment following traumatic brain injury can lead a decrease in the level of consciousness, causing relaxation of the pharyngeal muscle and subsequent airway collapse. Brainstem injury can impair the central regulation of breathing, potentially resulting in hypoventilation or apnea. At the same time, damage to cranial nerve 9, 10, and 12 can affect swallowing and tongue position, leading to airway obstruction. Structural damage such as maxillofacial fracture can cause instability and soft tissue swelling or hematoma formation, obstructing the airway. Laryngeal trauma can result in fracture, edema, or hematoma formation, compromising the airway. Additionally, cervical spine injuries can cause secondary airway obstruction due to hematoma, soft tissue swelling or spinal shock affecting diaphragmatic movement. That's all from me. The next will continue by my friend. Thank you.
Hello, my name is Putu Dinda from Sudastra, with my student number is 130. Today I want to explain about the pathophysiology of neck trauma. The pathophysiology of neck trauma greatly depends on how the injury occurs, given that the neck is an anatomical structure comprising many vital organ systems interconnected with each other. According to National Emergency X-Radiography Utilization Study 1 criteria, injuries classified as low risk typically do not involve spinal damage under the following conditions. For the first one, alert and oriented, no signs or symptoms of nerve damage, no tenderness of the spinous processes, and not intoxicated. Zone 1 is particularly dangerous due to the presence of critical organ structures such as the mediastinum, great vessels, and the esophagus. The most common cervical injury in penetrating neck trauma is vascular injury, characterized by severe bleeding that is difficult to control, decreased or absent pulse, rapidly expanding hematome, audible bruit, neurological deficits, and shock refractory to fluid resuscitation. And then, mild penetrating neck trauma presents with symptoms such as dysphonia, dysphagia, localized hematome, mild hematemesis, and hemoptysis. Neck trauma occurring in zone 1 and 3 should be monitored closely due to the higher risk of hidden vascular injuries and the possibility of concurrent injuries in the head, chest, or abdomen. So that's all from me. Thank you.
Okay, hello, my name is Putu Diva Artha with 3 last digit number 238. So I'll continue the explanation about the history and physical findings of head and neck trauma. Okay, so the key components of the history include the mechanism of injury. So information about the force, direction, and context of the injury helps predict injury patterns. And then symptoms like pain, numbness, visual or auditory disturbance, and respiratory difficulties are critical indicators. And about the medical history, conditions such as anticoagulant use or previous head injuries can influence management and prognosis. And then the timing and course. So the time of injury and progressions of symptoms guide the urgency of intervention. And then about the physical examination, we can do inspection. So in inspection, we can find some like lacerations, bruises, swelling, and deformities, and then signs like betal signs and raccoon eyes. And then from the palpation, we can do gentle palpations to detect the tenderness, crepitus, and deformities. And then from the neurological examination, so a detailed cranial nerve examination is essential as a deficit may indicate specific locations of injury. For instance, anisocoria can signal increase intracranial pressure or cranial nerve injury. And then from the airway and breathing, so symptoms such as stridor, hoarseness, or subcutaneous emphysema suggest airway injury or obstruction. And then from the circulation, carotid bruits or diminished pulse may indicate vascular injuries. And then from the special test and imaging, they can provide detailed visualization of bone fractures, intracranial hemorrhage, and soft tissue injuries. Maybe that's all from me. Thank you.
Good morning, everyone. My name is Meikel Wibisono with the last 3 digits of student number 061. And now I'll explain about the evaluation of head and neck trauma patients. So, to effectively diagnose and manage injuries such as the trauma must be evaluated using a systematic way. There are methods for evaluating head and neck injuries with a focus on clinical assessments and imaging modalities, such as for the clinical assessment, there are primary evaluations. So the primary evaluations of head and neck trauma entails a fast assessment to identify the potentially life-threatening problems using the ABCDE technique such as the airway, breathing, circulation, disability, and exposure is recommended as an initial evaluation framework in the Advanced Trauma Life Support or ATLS guidelines. And the next one is using the Glasgow Coma Scale, which is the GCS, is a commonly used technique for determining the level of consciousness in patients following head injuries. And also, there are several imaging modalities such as the CT and the MRI scan. So the CT or the computed tomography imaging is the gold standard for assessing head and neck trauma due to its great sensitivity and specificity. So, CT scans can promptly detect fractures, cerebral hemorrhage, and soft tissue injuries. And also, the use of multi-detector CT has improved diagnosis capabilities by enabling the detailed viewing of complicated anatomical figures. And also the last one, MRI, is especially used for evaluating soft tissue injuries and detecting diffuse axonal damage or DAI, and which may not be seen on CT scans. So that's all from me. Thank you.
My name is Dewa Rajeshi Arikandini with the last 3 digits of the number 188. Now I will continue the presentation with airway assessment in head and neck trauma patients. The success of airway securement is crucial in the management of trauma patients who have a higher risk of intubation difficulties compared to other patients requiring tracheal intubation. One of the conventional tools that can be used to assess airway difficulties in patients with head and neck trauma is the Lemon method. The Lemon method encompassing of the assessment of look, where we need to look externally for facial and neck injuries, evaluate patient's mouth opening with 3 fingers, Heoid to metal distance with 3 fingers, thyroid notch to Heoid with 2 fingers, and then Malampati, which classifies into several classes. Class 1, where the soft palate, uvula, and pillars are visible. Class 2, where the soft palate and uvula are visible. Class 3, where only the soft palate and base of the uvula are visible. And class 4, where only the hard palate is visible. And then obstruction, to see if there is any obstruction in the airway, such as hematomas or soft tissue oedeme. And then neck mobility, to see if there is any restriction in patient's neck mobility.
Om Swastiastu, doctors and friends. My name is Putu Isyundra Kesuma, last digit number 003, and I will explain you about the airway management in head and neck trauma patients, especially on pre-hospital trauma management. So for the management, it's focusing on oxygenation and also ventilations, along with rapid transport to a trauma center as the main priority. And the majority of trauma patients are managed by supplemental oxygen and also basic airway maneuvers. So for the initial management, we have to ensure some things such as, is the airway open, is the oxygen saturation adequate, is the patient ventilating, and if yes, we could do supplemental oxygen, but if no, we could do airway maneuvers such as jaw thrust. And after basic maneuvers, we could ask the same questions. If yes, we still can do supplemental oxygen, and if no, it's depend on the transport time. If the basic maneuver is not adequate, we have to support it with BVM or back valve mask. If the back valve mask success and transport time is under 10 minutes, we could transport the patient to the nearest trauma center. But if the BVM not adequate and the transport time is more than 10 minutes, we could do advanced airway management such as rescue airway or orotracheal intubation. And if all methods fails, cannot intubate or cannot ventilate, we could do surgical airway options such as cricothyroidotomy. I think that's all from me. Next will be explained by my friend. Thank you.
Hello, my name is Nyoman Medhira with last digit of study number E070. Now I will explain about the specific airway management in head and neck trauma patients. First, there is maxillofacial injuries, especially fractures, pose significant challenges in managing the airway due to several factors. Fracture segments can move backward, causing collapse of soft tissue that obstruct the airway. Blood pooling in the throat can induce gagging or vomiting, worsening the obstructions. For the management can be proper patient positioning, manage their own secretion effectively, ensuring their cooperation for pre-oxygenation during rapid sequence intubation, achieving a good seal with a back valve mask device. Second, the traumatized airway. It is important to exercise caution with positive pressure ventilation as it has the potential to worsen complications. For the management, direct visualization plays a critical role in ensuring safe placement of the endotracheal tube to prevent incomplete injuries from progressing to complete transection. Utilizing a flexible intubating endoscope under direct visualization is recommended. Next is head injured patient. Traumatic brain injury is the most common cause of mortality in trauma patients. For the management, ATI for airway protection to prevent aspiration must be weighed against the risk of the occurrence of physiologic adverse events known to increase morbidity and mortality in TBI patients. IBA and functional airway obstructions may be correctable with simple airway opening maneuvers with or without brief ventilation support. Last is suspected cervical spine injuries. For the management, imaging should not be delayed. The provider should optimally use the intubation device that he or she most experienced with, and be prepared for a poor view with direct laryngoscopy. So that's all from me. Thank you.
Next, let me introduce myself. My name is Leonyta Augustyne with last 3 digits 150, and I will explain about the complications of head and neck trauma. So, complications of head and neck trauma is a severe life-threatening condition, which the most potential complications come from airway obstruction. The causes of airway obstruction can be dense blockage, such as relaxed inflammatory tongue, or liquid blockage, such as blood from excessive bleeding from the nose, mouth, or throat, and vomiting that can also be the obstruct airway, especially if the patient is unconscious. The swollen face, neck, or throat can obstruct the anatomy and block the airway, causing respiratory distress, collapse, or damage, leading to obstruction. Other than airway obstruction, respiratory distress and function failure can also be a fatal complication of head and neck trauma incidents. It comes from mild anxiety, minimal but persistent cyanosis, tachycardia, and altered breath sounds, and decreased oxygen saturation. Another complication of head and neck trauma is aspiration of body substance that causes respiratory failure, vocal cord paralysis, perforated esophagus, and esophageal fistula that can lead to infection. Airway injury to the lung and vascular vessel can lead to pneumothorax, hemothorax, and air embolism condition. General complications of head injury can impact the brain, causing several life-threatening injuries such as intracranial pressure and soft tissue injuries caused by blood or penetrating trauma. All of the mentioned complications require qualified airway management to prevent worsening condition. Mistreated airway management can result in prolonged hospital stays and rehabilitation periods, leading to significant morbidity and mortality. That is all from me. Thank you.
Hello, my name is Karralika with the last digit of student number 246. And now I will conclude the student project from our student group discussion B9. Head and neck injury are serious injuries that can lead to death and disability, with traffic accidents as the most frequent cause. The key components from anamnesis are mechanism of injury, symptoms, medical history, and time. In the physical examination, we can do inspection, palpation, auscultation, and neurological assessment. To evaluate the head and neck injury, we can go with the airway, breathing, circulation, disability, exposure evaluation, or the ABCDE evaluation, or with the Glasgow Coma Scale. The emergency airway management for patients with head and neck trauma injury must be carried out immediately if the patient shows signs of hypoxia, apnea, or gasping breathing patterns, trauma associated with hemodynamic instability, and severe traumatic brain injury. If the patient has any of the symptoms mentioned, give oxygen therapy, and if the patient has no response, provide with basic life support airway management. That is all from me and our student group discussion. Thank you.